So good morning, everyone. On behalf of the Wisconsin Alzheimer's Institute Regional Milwaukee Office and Center for Community Engagement and Health Partnership, welcome to the 8th Annual Minority Health Month event, Breaking the Silence, Addressing Dementia in Communities of Color, where this year's theme is Systemic Change Through Community. I'm Dr. Nia Norris and will be serving as the program facilitator for today's panel discussion, Navigating Care Through the Pandemic. April is National Minority Health Month, and in April of 2001, the National Minority Health Month Foundation launched National Minority Health Month in response to Healthy People 2010 to promote educational efforts on the health problems currently facing minorities and other health disparity populations. It is well past the 2010 initiative, and our communities continue to be impacted by health disparities. As many of you already know, dementia impacts communities of color at an alarming rate. African Americans are estimated to be 2 times more likely, and Latinos 1.5 times more likely to be diagnosed with some form of dementia. Today, we have come together to continue to break the silence about this disease, to educate our entire village as we learn from our own community how we can collectively work together to help our loved ones and our community families navigate through their journeys. We hope today is a day of learning, hope, and encouragement, and we know this is not the end, but just another step on our pathway. At this time, I'd also like to thank our sponsors and partners who have played a key role in ensuring that we could host this dialogue for our community today. Bader Philanthropies, My Choice Wisconsin, Community Academic Aging Research Network, Direct Supply, and Milwaukee County Department of Health and Human Services, Aging and Disability Services. As we move into the presentation for today, if you have questions for the panelists, please utilize the Q&A function at the bottom of your screen. We will get to as many questions possible, and for any questions that we are unable to answer during today's panel discussion, we will post answers to those questions on the event page of our website. A recording of this presentation will also be uploaded to our website. So now I'd like to introduce our moderator and panelists for today. Stephanie Houston, who will serve as our moderator today, is a senior program coordinator with the Wisconsin Alzheimer's Institute Regional Milwaukee office. She joined the WAI staff in 2009, and in her role, Stephanie provides ongoing assistance to cognitively impaired and medically underserved African American older adults and families who are seeking a proper evaluation and diagnosis for Alzheimer's disease or related dementia. Routinely, she performs in-home assessments, provides consultations, mediates family meetings, and assists families to develop a plan of care. In addition, she refers individuals for cognitive evaluations to local affiliated WAI dementia diagnostic clinics for treatment. Over 10 years, Stephanie has served as a member of the interdisciplinary team at Milwaukee Health Services, the first federally qualified health center with a dementia diagnostic clinic. And at MHI, she consults with families and provides dementia education materials, provides service links to community resources and support. Since 2014, Stephanie has served as also the coordinator of the WAI outreach program, the Amazing Grace Chorus. And the Chorus program is made up of individuals living with Alzheimer's disease or a related dementia, who sing with their care partners. And through music and social engagement, the program seeks to improve the quality of life of individuals and their care partners. Janice Johnson is a retired nurse who worked for Milwaukee County in various settings for 23 years. Her mother was diagnosed with dementia, and she retired 10 years ago to care for her mother. She has been the primary caregiver for the last 10 years until her mother passed away last month. Dr. Carla Wright has spent the majority of her career working right here in Milwaukee in the unique field in which she has expertise, rehabilitation medicine and geriatrics. Originally from Detroit, Michigan, Dr. Wright is a graduate of Vassar College with a degree in biopsychology. She also attended the University of Michigan School of Medicine, completed an internship at Henry Ford Hospital in Detroit, Michigan, and went on to complete her residency at Northwestern University School of Medicine in Chicago, Illinois. During the 1990s, MHSI, then known as Isaac Cogs, It had a unique working relationship with Curative Rehabilitation Hospital, which ran a satellite clinic in the COG Center. Dr. Wright was presented with the opportunity to enter a relationship that enabled her to combine her medical expertise to work with the elderly population and provide outpatient rehab services, while simultaneously enabling the COG Center to provide these unique services in the central city. Since then, she has partnered with the University of Wisconsin-Madison to help manage dementia and aging in African Americans. Teresa Scora is a nurse practitioner and serves as the memory clinic coordinator at Milwaukee Health Services. Teresa received her undergraduate degree from Alverno College, a graduate degree from Marquette University. Teresa has worked as clinic coordinator for the memory clinic at Milwaukee Health Services since 2009. Teresa collaborates with a multidisciplinary team to evaluate, diagnose, and treat memory loss. Teresa's responsibilities include educating and scheduling individuals for their memory evaluation and administering the cognitive testing in the clinic. In the past, she has organized memory screenings in the community at senior apartments or senior centers and has been a facilitator for the Healthy Body, Healthy Mind Connection classes. In the clinic, Teresa also conducts Medicare wellness visits. Outside of work, Teresa serves on the HDSA Wisconsin board and volunteers at the Open Door Free Clinic. Anna Bernal is a nurse, a bilingual nurse at the Latino Geriatric Center Memory Clinic, located at the United Community Center, Milwaukee, Wisconsin. The Latino Geriatric Center Memory Clinic is a community-based memory diagnostic clinic for Latinos, a collaboration with the Medical College of Wisconsin and the Alzheimer's Association. In her role, she operates as part of the bilingual memory clinic team, along with the social worker and MD, conducting memory screenings and assist the MD during clinic days. Due to the pandemic, the memory clinic team added the option of tele-assessments to continue providing cognitive assessments. Prior to this position, she worked as a nurse case manager and later on as a lead nurse for My Choice Wisconsin for about 6 years. She has previously worked at First Med Staffing, providing immunizations and wellness checks throughout Milwaukee and Waukesha areas for several years. She has a BS in nursing from Concordia University of Wisconsin, Mequon, and is a member of the National Association of Hispanic Nurses, the Greater Milwaukee chapter. Thank you all so much. And now I will turn it over to our moderator for today, Ms. Stephanie Houston.
Thank you so much, Dr. Norris, for those wonderful introductions this morning. But before we begin our panelist discussion, I want to share some statistics. According to the Alzheimer's Association, there are over 120,000 individuals living with Alzheimer's in Wisconsin, and over 196,000 individuals providing care. Nationwide, there are more than 6 million people living with Alzheimer's disease. People living with Alzheimer's or related dementia are among our most vulnerable in our community, and this was proven during the pandemic. According to the Alzheimer's Association regarding mortality rates, there were 881 more deaths in Wisconsin from dementia in 2020, citing a 15.8% higher rate increase. In addition, there was 16% increase in the use of hospice and a 19.9% increase in the use of hospitalization services. According to the Wisconsin Department of Health Services and the Wisconsin State Data Reporting, there were over 1.6 million confirmed or probable cases of COVID-19. Since the first confirmed case on March 6 of 2020, there have been a total of 231,019 confirmed cases of COVID-19 in Milwaukee County alone. State data reports that Wisconsin's Black, Indigenous, and other people of color have been disproportionately affected by COVID-19. Inequities led to increased higher rates of COVID-19 cases, lower vaccination rates, increased hospitalization, and a number of deaths. According to our leading national experts, the pandemic has entered into a new phase. COVID-related deaths and hospitalizations are low, but the virus has not been eradicated. Globally, the Omicron variant BA.2 is causing COVID cases to rise in Europe. Currently, Wisconsin has a total of 61% of its population vaccinated, and only 34% have received an additional booster dose. With the emergence of variants, there has been a new increase of confirmed cases that has risen now to 1,159, according to the 7-day average. Experts are still recommending that people get vaccinated. And this is going to lead me into the first question for our guest panelists, navigating care through the pandemic. Once again, welcome panelists. Thank you so much for being with us this morning. And I'd like to begin with the first question. Why is this topic of navigating care through the pandemic so important right now to this audience? And I'd like to start with you, Anna, if that's okay.
Yes. So during the pandemic, we heard that African Americans and Latinos had higher mortality rates related to COVID-19. And it was mentioned that it was due to environmental health disparities associated with demographic area that they lived in. I also learned that Milwaukee is one of the most segregated cities in the United States, and that is due to their history of redlining. This redlining affected minorities in more ways than one, which is inadequate living conditions, poorly funded education systems, being further away from adequate shopping, medical, and other social services, as well as a host of urban issues. Looking at the COVID-19 cases and the zip codes in Milwaukee that were more impacted than others, I could see that it shared similarities with the redlining areas where more minorities are congregated. In regards to the Hispanic or Latino population, it was noted that the health and financial risk factors associated with non-citizen immigrants due to COVID-19 pandemic included living in larger households, being essential workers of work that cannot be done virtually, transportation, either needing to take public transport, and being uninsured. I believe that it is important to learn how to navigate care through the pandemic because in a nation that's supposed to have the most opportunities, there seems to be limited resources for some. So it is critical for this audience to evaluate how the pandemic affected accessibility to diagnosis, care, and support services. In our clinic's case, is supporting and caring for someone living with dementia.
Thank you so much, Anna. And to Teresa, why would you say this topic of navigating care through the pandemic is so important right now to our audience to hear?
Well, I think, like you said, right now we're in an interesting time with the pandemic where people almost have kind of taken a step back and think that almost we're back to normal. So I think in a sense, we need to evaluate the pandemic in the sense of still being very cautious and also noting that it doesn't mean that we're going into a new phase, that things are over. The other thing I think we need to realize is that as we go forward, there is this realization that people coming through the clinic, through our memory clinic, are going to have either been exposed to or have had COVID. And knowing how that the virus will affect them in more the long term with either their chronic medical conditions or their memory itself. In our memory clinic now, that's one thing that we have added to is looking at, have you had COVID? And do you think that, now it's contributing to any of the issues that you are having with your memory loss? So navigating care through it, and also people have, I think, I almost call it the pandemic pause, where everyone stopped going to receive their care in the first part of the pandemic. So now it's almost like we're doing a lot of catching up also. So there's a lot of parts and different wheels that are turning through. Now we're going through a different phase with the pandemic and trying to navigate care and get into care and get things done that maybe people weren't able to get done previously.
Thank you so much, Teresa. And Dr. Wright, do you have a message for our audience as well in regards to navigating care through the pandemic?
I have to say kudos to the patients and their caregivers, because it has been a very difficult and challenging time. I think it's been difficult for the healthcare professionals as well, because this is a navigation. This is something really quite new in today's medical age, where we think when we have a disease, we have a cure right away and it gets better and it goes away. And I have to say, this is the first time in my medical practice, and I've been a physician for 32 years, where I've actually seen something like this, kind of like a plague, if you want to say, if you go back in history, where it shows up, we don't know where it comes from. We have to screen everybody for it. It takes certain people out. It changes just patterns, socialization. It creates isolation, despair. People having economic decline. And you might say, okay, what if this gets better? The whole thing is it has changed our whole community in terms of depression and isolation. Forget about actually getting the actual virus and being down 4 weeks, or even getting over and being a quote unquote long hauler with shortness of breath or fatigue or bleeding or inflammatory markers or whatever your long haul is. I think it has really changed society quite a bit in terms of just being more isolated and disconnected. And I worry about not just the pandemic and the actual virus itself, but just some of the changes that have occurred. People have put off regular screenings for things just because they had to get a test, and some of the invasive things that we get, like colonoscopies and other exams that are done in person, I know have been postponed. So that's something else that everybody, whether you have COVID or had a family member with COVID, or whether or not you're just caring for them and you've been too busy to take care of yourself. So there are a lot of things to be concerned about, even after we get through this hump and we have an idea or a handle on where this is coming and where it's going to go in the future.
Thank you so much. And our next panelist, Ms. Johnson. Can you add in regards to navigating care through the pandemic and why this conversation, this discussion today is so important to the audience?
Well, I took care of my mother in my home. So my scenario might be a little different than some other people, but a lot of my family used to laugh at me because I would not let anyone in my house during the pandemic. You know, I didn't care if you had a mask on or what, but nobody was coming over to see her or to get close to her. So I kind of kept her isolated. You know, most of the time she saw only me. I did have an aide that came in to give her a bed bath a couple of days a week. She always wore a mask. I actually had to have her doctors. I found a doctor that would come to the house.
Wow.
I found a podiatrist that would come to the house.
Wow.
And so I also found someone to come give her vaccine here at the house.
Wow.
So she was bedbound. So, you know, she wasn't up walking around. I couldn't get her out to appointments. So it was different. You know, and I know there was a lot of isolation for her, but she got the best care that I could give her, and I kept her safe. That was the main thing.
And Ms. Johnson, we want to just say thank you so much for being willing to continue to be a part of the discussion today. And we wanted to acknowledge, you know, that your mom had passed away. So we really thank you for being on today and sharing that perspective, and definitely all that you did in order to keep your mom safe. And that also leads into the next question in regards to some of the biggest challenges. I mean, one of the things is that you realized your mother's health condition made her very vulnerable. So you really made keeping her safe a priority. And I'm listening to all of the things that you said you put in place. You were able to find a doctor, and just be able to. We appreciate that. At the height of the pandemic, what challenges were you facing, like so many other caregivers?
Well, one of the things Dr. Wright alluded to was taking care of myself.
Yes.
Because before the pandemic, I used to go to the gym 5 days a week. And, of course, that stopped because that closed up. So my self-care wasn't where it should be. I also have not had my colonoscopy because I would not go during the pandemic. So I do have to do that. So, just taking care of myself was kind of a challenge. And my main focus was just to keep her safe.
And we thank you so much for your efforts and being able to share your story and your journey with us this morning. And Dr. Wright, you as a primary provider, I know that, in many cases in the hospital, elective surgeries were no longer happening. But in the case of like Ms. Johnson, what were some of the biggest challenges that you would say people were facing in the community? And with you having more of a specialty practice, being a champion physician over the memory clinic there at MHSI and really specializing in older adult health, what would you say were some of the biggest challenges people, caregivers were facing and individuals living with the dementia were facing?
Well, I think it's twofold. Again, getting that patient out or having some kind of communication with a caregiver, given the fact that in many cases people are immobile, such as Ms. Johnson's, and I had to figure out how to get some of my patients who were just not ambulatory in to be evaluated by a nurse or by a physician that comes to the home. And that was a bit tricky depending upon a person's insurance and what their last hospitalization was. A lot of it will go with what the diagnoses are and whether or not the person is mobile or not, in terms of forcing somebody to get in a wheelchair and get transported there in the midst of all this versus having a home physician. So yeah, that was a big thing, but more importantly for the patients themselves that weren't necessarily dementia patients, again, just the patients that came to me for regular treatments, many times they were putting things on hold, but just because they had issues with their elderly or sick or anybody that was invalid, whether it was a child, somebody that was a good friend, they were pretty much having to do a lot of cares at home until they could set up individual people that could actually come in. Nobody really wanted to put people in long-term care facilities, and a lot of the folks that were already in long-term care facilities, people had concerns about it. They were locking the doors. They were not letting the loved ones come in. They got quarantined for that. And then when people were being tested, many times folks did not understand what the tests were showing and how they were isolating the individual occupants or people that lived there, and from the safe people that were testing negative versus the people that had COVID. Right. And I think people had a lot of fear for people that were already in long-term care facilities, quote unquote, which had been fine because it was almost a closed door and folks couldn't get in. I had a colleague who had to place someone in a care facility, and Ms. Houston helped her with that. And that was hard for her. And she had every single asset available to her financially, just walking through the process of making sure that her loved one, who was indeed, deteriorating in front of her, she had him at home for as long as she could, but as a full-time physician, she realized things were out of hand. And so Ms. Houston was able to help place her. And she had a lot of drama and trauma, even though the facility was less than 15 minutes away. She had a camera in the room at one point. I shouldn't be saying this. And then at one point it was taken out when quote unquote things were okay. But it's been drastic for anybody that had a loved one that was needing to be in supportive care outside the home or was in supportive care. So I think it kind of, you know, you're talking about, we are talking about minority populations, but it was just, I think, you know, it's been a really kind of like a tornado hurricane across all strata for real. It just in terms of deaths and maybe permanent impairment, the numbers seem to be higher, you know, in the minority populations, especially in the metropolitan areas and in indigenous lands here in the state. Yes.
Thank you so much. And Teresa, did you want to add in regards to some of the biggest challenges people were facing during the pandemic?
Well, two things I wanted to add. The nice thing, our memory clinic only had to pause for a couple months, which was nice. But during that time in the very beginning, you know, from about March, I think we restarted up in July. But I think you still had, you know, chronic conditions still continue. That, you know, people were still having issues with behaviors. People are still having issues with getting into care and getting a diagnosis and things. So I think those were some of the biggest challenges, is trying to figure out what you need to do when specialty services are shut down, and how to get care when some of these examples, some of it you could wait, but some of it is you need to have it done. So how do you kind of look through the system and go, okay, how do they get to be seen for this? Or if a behavior is so bad, and again, Stephanie would help us out with patients if families and things were calling and we're going, okay, if they need to go somewhere because they're not safe in the home anymore, where can they go? And the other thing is, I had you know, people were being told not to go to like urgent cares and ERs unless it's almost like you are stepping on death's door. So the bad part of that is that sometimes I would get somebody calling me who was very short of breath and very sick, but did not want to go because they felt like they were supposed to be staying home because there was no rooms in the hospitals and things. And that, I think, was one of the biggest challenges, is kind of like this mixed message of, okay, when should you be going in? And I think there are some people who, you know, had bad effects from waiting too long to get into care because they thought they weren't sick enough to go to the hospital, go to the ER, go to an urgent care and be evaluated.
Well, thank you so much. That really, you know, has given us some great insight in regards to how people were accessing care, the burden of care for individuals, and how this pandemic was really impacting our community. And Anna, I'm going to reach out to you and I know you were able to give us some, at the beginning of the presentation, share with us some of the challenges for the community, but I also want you to add as well in regards to some of the biggest challenges people faced as well in our community.
I think the biggest challenge that we saw in our Latino population, from our patients and even family members and people out in the community, was mistrust of what was going on. There was so misinformation or so much different, like contradicting information in regards to COVID-19 that people didn't know who to listen to. And it became more of a political arena than anything. So then people were siding more with one area. And then there's already mistrust within our community in regards to the healthcare system because we don't know how to navigate it very well, or we don't understand, or we're more towards the natural part of it than anything. And because of history too, there's like history events that have happened that have really not contributed to the trust between healthcare provider and our minority communities. So trust was a big issue in regards to the vaccine. A lot of misinformation that people were reading. People were saying, you know, you're going to get sick from the vaccine, or you're going to go a third eye, or, you know, the big thing was you're not going to be able to have children. You're not going to be able to bear children. So a lot of people were like, don't get the vaccine if you still want to have kids. Even my mom, she's in her 50s and she's like, no. And I'm like, you're not going to have any more kids, Mom. It's okay. Get it. You got to be safe, protect yourself. But a lot of misinformation, and there was beliefs too that played a role into, you know, getting vaccinated or being protected and being safe. And then access to care was another big issue, especially for our immigrant community that don't have insurance, are undocumented. Access is a big issue. A lot of people, I believe Teresa mentioned this, in regards to the hospitalizations, people were fearful of getting hospitalized because they said, once I'm hospitalized for COVID, I'm dead. That's what it means, because I'm gonna get intubated and I'm gonna die. And everybody just decided to take care of themselves at home with natural remedies and things like that. Another thing was grieving. Grieving was very difficult for our community because you have family members in Mexico, Puerto Rico, Guatemala, other places that don't have the access to healthcare that we do. And then there were people dying. You couldn't travel at the time. You couldn't visit them. You couldn't see them. Even here, personally, people not being able to say goodbye to their loved ones or visit them or see them. The grieving process was very difficult, very different. And a lot of people that were caring for people with dementia, our communities live like multi-generational homes.
Yeah.
We could have like 5 different families in the same home sometimes too. So that didn't help, where the kids went to school, if they were going back in school, because sometimes it was virtual, and then they would bring back the sickness, or people were going out to work and then coming back in and then bringing it to their grandparent or whatever. And then the guilt that comes in with it, like, you know, they got sick because of me. So all of those were issues during the pandemic that I still see that there's still some limitations and some of those mistrust issues, but yes.
Well, one of the things is that was some wonderful insight in regards to what was happening in the community, the misinformation, also just the issue of access, and also, you know, people just not knowing where to go, people having high rates of infections because of just the way they were living, multi-generational housing. All of these were significantly impacting the community. And I just want to say, Anna, you and Teresa and Dr. Wright both are in the memory clinics, our affiliated memory clinics with the Wisconsin Alzheimer's Institute. And you were among several clinics, some of the only clinics who actually stayed open during that time. And so, Anna, if you didn't mind, please tell us a little bit more about your memory clinic and what someone could expect from a visit.
Yes. So we're the only bilingual, fully bilingual memory clinic in Spanish and English in all of Wisconsin. Before the pandemic, we were doing mobile home visits because we know transportation and location was a big barrier. Before, I believe the memory clinic here at UCC started since 2007, and it was working with Frederick and the Medical College of Wisconsin out of their location. The issue was that there was a lot of people that were no-shows, either due to transportation, not knowing how to get there, getting lost. And then the Frederick Hospital is like so confusing as it is. It's connected with children's, there's so many buildings. So that was another issue. So the mistrust was also an issue. So then what we did, the UCC did, is that they changed the clinic to the heart of the community, a place where the people are already familiar, that are used to serving the community. And UCC has been serving the community for many, many years in different aspects. Right now, they're serving anybody from 6 months and until whenever God decides, you know, it's time to pay a visit or whatever it is. But they changed the clinic here. So it makes it easily accessible to the community. And by offering mobile home visits, we were able to meet the people where they were at. And it allowed us to get a greater picture in regards to the memory assessments through observation and being able to complete home safety evaluations. So I would be with the patient in one area of the room, usually the kitchen, so I could have them do the testing on the table and things like that. And then I would have them do what in my choice family care is called the long-term care functional screen. I would physically observe them transferring, walking. I would ask them, like, you know, show me your room, show me the bathroom. Are they able to regulate the water temperature? Are they able to, you know, get up from the toilet? Do they need any DME? If there's any safety hazards? Is there anything that we could supply them with at this time or connect them with any community resources in order to maintain their safety in the community for as long as possible? Because as we know, with our Latino population, familismo or familism is very important. We take care of our own, and placing somebody in a home, it's not an option. So we want to be able to be supporting the caregivers and keeping their loved ones as safe as possible in the community. And then we did in-clinic visits for those that didn't feel comfortable having strangers coming to the home, because we know that there's also that mistrust, like, who are you? What do you want? What are you gonna do? Are you gonna place me in a home if you visit me? So allowing them those options really helped. But during the pandemic, that was like a big change. So we had to change everything to telehealth, try to figure that out, trying to make it safe in a way that we could give them access to telehealth services. And then we've addressed the stigma surrounding dementia through education. Education is a big part, because a lot of people think dementia, oh, it sounds very much like demented, which is like demente, which means crazy in Spanish. So people thought, oh, no, let's not go that way, because it just means that you're crazy, you know, just forget about it. It's like the elephant in the room. And through education, we made them aware that that's not the case. So yeah. Oh, and our doctor is also able to see, we're able to see in our clinic uninsured people. So people that have undocumented, anybody, we serve anybody. There's no, like, no, you don't have insurance, we don't see you. No, you don't have papers, we don't see you. No, we see you, because we know that this is a big necessity in our community. So we want to make sure that they have the same access as anybody else would have. So our initial screenings are completely free. And then it's bilingual, we have many people, Italian, Puerto Rican, Mexican, we understand the culture. And that's what's very important, because many people report that, you know, going to a doctor that doesn't speak their language, doesn't know their culture, really they feel misunderstood or not understood, or they just feel like, you know, I just want just to get the checkup and just get it done. So there's the reading in between the lines of that cultural aspect that our clinic offers.
Thank you so much for sharing that information. And your clinic is a lifeline in regards to linking people to that access of healthcare. And even in the midst of the pandemic, you were able to do that in such an innovative way. And I know you'll share a little bit more about that as well as we go along in the conversation today. And Teresa, I know you are the coordinator of the Memory Clinic at Milwaukee Health Services. Can you just share a little bit about the Memory Clinic at Milwaukee Health Services and what someone can expect during a visit?
Our memory clinic here at Milwaukee Health Services is a specialty clinic within our internal medicine department. We started about in 2010, and we have a team of people who evaluate the patient and help the caregiver and the family. And so I'm the coordinator. Dr. Wright is the physician champion, and then Stephanie has been working with us since the very beginning, and she helps us with anything and everything with the patient and the family outreach resources, things like that. Our memory clinic, our referrals come mostly from providers within our clinic. We're a federally qualified health center, so we have a lot of different specialties under one roof, but the majority of our referrals will come from family medicine, internal medicine. We do now also take referrals from outside of our clinic and from other, through the years, it's been kind of fascinating, the different referrals that we've gotten. Sometimes some people just find us on the internet. We got someone recently from a psychologist who knew something was going on with the person they were seeing, and they were referred to us. Sometimes dementia care specialists will have people that then come to see us. And our evaluation, mainly what we're trying to do is, as you know, Anna said, you want to keep people safe, you want to keep people in their homes, you want to keep them safe and in their homes as long as possible. But our evaluation is to kind of also tease out, because there's many different reasons that people have issues with their memory. And our evaluation is a two-part evaluation. They do come and see me for an hour, and I do the neuropsych testing, and then we get some history. And then on a separate Tuesday afternoon, they do see Dr. Wright for the medical part of the evaluation, which is a lot of like review of systems, physical exam, and a little bit of testing. And then our clinic, we're teasing stuff out by ordering labs, and a lot of our patients, we do want to get additional imaging of the brain or an MRI. So what we typically do is do the evaluation, make some recommendations. Majority of people, we want to get an MRI. So we're saying, hey, go get that MRI and then come back and see us in 2 months, or longer if it needs to take you longer to get the MRI. Because what recently we have figured out is that we were losing a lot of people to follow up. So we would see them for their 2 visits, and then it would be hard to get in contact with them again or have them come back in for many different reasons. And so now we're trying to have that additional connection by, okay, come on in, we'll go over your MRI with you, reinforce. Do you need to get into behavioral health because there's some anxiety, depression, something else going on? Are you having a lot of sleep issues? Need to be seen somewhere else. So trying to get them in for that initial, it's almost like they get touched 3 times, and then based on what our results are, we bring them back in. It's sometimes 6 months, sometimes a year, depending what all is going on and what further evaluation needs to be done. I think, Dr. Wright, am I missing anything?
And Dr. Wright, can you just share with us what's the benefit of someone being seen in a memory clinic, such as yours, as the champion physician who oversees the clinic? What is the benefit?
Yeah, I think it's always good, you have everybody that, practices medicine and they have their practices. I think it's good to have, as again, a specialty clinic where there's a couple different sets of eyes looking and keying in on just certain things, because as people get older, there are a lot of things that are going on, and sometimes when you're seeing somebody over a period of time, the gradual changes are maybe not as noticeable unless a family member or somebody who has not seen that person says, your mom's just not as clear as she used to be, or what do you think about that? Mm-hmm. And so I think many times we get referrals for this assessment, because sometimes people do age slowly, and it's not as noticeable to their regular primary care. Yeah, it is a referral clinic. It is not for total care. It is for just the memory evaluation and then follow up. And that keeps it real in terms of my load. But I think as people sit back and look at things long term, or when the family member or even the person says, X, Y, and Z is not like it used to be. I've had some of my patients that I had been seeing in my internal medicine department over years say things aren't right, or I say things are not right, and I will do a very short test, either the MMSE or something like the Minicon, and I'll say, hey, you know what? This has gotten worse. So you need to get into the memory clinic. And we do encourage our providers that are our primary providers to do that as well. But yes, I think, a referral from somebody's primary, they need to have a primary, I think is fine, and we can assess them. The big issues many times come with family members. Sometimes family members don't agree that, mom or dad is really changing, and some of that is fear. And you find different dynamics, as Stephanie will tell you, within the family members. Sometimes when people come in with their family members that they have concerns about, things they just cannot believe, because this is a strong person, they've always run everything, they're still looking stately, and they still are quote unquote trash talking in a fun way, they haven't given up the fight. But clearly when you sit down and you examine them, maybe with other family members, and see how things have changed, there really is something that needs to be addressed. And sometimes it's harder than others, as Stephanie will tell you, to not just work with a patient that's being asked to be seen, but to work with the family dynamics. And that's a whole separate issue. But it's worthwhile, I think, for folks to get tested on a regular basis.
Thank you so much for Anna, Teresa, Dr. Wright, for the incredible work that you're doing, and also being able to stay open even in the midst of pandemic, and being that link for individuals who needed evaluation and care. And so as we're kind of winding down, and as we're kind of going through this phase of the pandemic to an endemic, but as I said, the virus has not been eradicated. I just want you to be able to share what is something that you've had to implement or methods now since the pandemic in regards to your work and in regards to keeping people safe who come and see you. So I'll start with you, Anna. What are some tools or methods your organization has had to implement in order to keep yourself safe as well as the patients safe who come for care?
Yes, so like I mentioned, one of the biggest things was our mobile home visits and then doing the in-person visits. And when the pandemic hit, everything was closed, even UCC. So we had to figure out what would be the best way to continue to serve our community. And everybody was switching to telehealth. We're a small community clinic, we're a diagnostic clinic only. So we're still in the Flintstone era where everything's paper. There's no electronic records, there was no telehealth services. So we had to figure that on our own. And the way that we did that is through trial and error. And then we knew at one point Zoom was getting hacked. So then, the HIPAA compliance of it wasn't easy. And then trying to do WebEx, people weren't understanding WebEx, the downloading process and all of that stuff. And then that led us into DoxyMe. So DoxyMe, we're able to use, it's a HIPAA compliant platform that medical providers are able to use. This is not a paid advertisement, just FYI. And then what we do is that we could send them an email link to them so that they could sign in, or we could text the link to them. So then through text, they just click on it on their phone. It automatically takes them to a page. A pop-up will appear where it says, enter your name. They enter the patient's name, put enter, and then that's it. They're automatically in the waiting room. So then it makes it so much easier for the caregiver to do. But during that process, we also realized that connection was a big issue. Some people had poor connection in the areas. If they live in the areas where, like my mom lives, which is a big area where Hispanic population resides, it's a dead zone. It's a really dead zone. So people that only had a smartphone available didn't have internet access. So internet access was also an issue. So then we had to figure out how can we still meet the needs of our community in a safe way. What we did is that we ended up buying Chromebooks with hotspots, headphones with headphone covers, and then we put them in Ziploc bags or like a plastic bag that we're able to dispose afterwards. And then the social worker or myself would then coordinate with the caregiver. Okay, set date is your appointment. 1 hour before the appointment, the social worker will go and deliver the equipment, gowned with her gloves and her mask, making sure, she calls them, hey, I'm outside. They would come outside, hand off the Chromebook that was already set up. They didn't have to do anything. All they had to do was open it up. They were already set up and waiting for me to see them and start talking to them, get their medications, get the consent forms, get everything ready. And then once we were done, they just had to close everything up, put it back in the bag. We call them once we're outside, either the social worker or myself will go once again, gowned up, pick it up, and then sanitize the equipment all over again. So then we will keep doing that in order for people to have access to our services through that area. In person, how once everything was like, okay, we're opening up a little bit, but with caution, is that we were still offering like our providers, if we had N95s or KN95s, we would use those. If not, we don't have that available because, at one point it's like, no, don't buy them unless you're in a hospital. So then we would double mask and then wear the face shields for our initial visits because they could take anywhere from 1.5 hours to 2 hours, sometimes 3 hours, depending how long the caregiver mostly also wants to vent. And we want to establish a rapport because through communication, through the things that are not in the questionnaires is where you find more information like, hey, that is very helpful to know. It wasn't in the question or they answered it differently, but not through a story. They're spilling the beans without knowing it, So then we're able to do that by making sure that we have the guards, the plastic things that go around, and then the social worker's in a larger room where she's able to stay 6 feet away from the caregiver. And then me with the patient, we're in my room, but we're both protected, both wear a mask. If the patient didn't have like a surgical mask, they had a cloth mask or those gaiters that go up to your nose, we would provide them with a sufficient mask that they could wear instead. We also call them before their appointment to remind them of the appointment. And at the same time, we do a COVID-19 symptom checklist, go over, do they have any symptoms? Have they been in contact with anybody that tested positive? Have they gotten their vaccines? That kind of stuff. And then the day off, we check their temperatures. Once again, we go over the list because we know anything could change from day to night. They're like, oh, you know, after you called me, my grandson came in and he was like sniffling and he got all over me. And we're like, We had a case where the patient's husband was very sick. He was coughing his lungs out in the telephone. And then they're like, no, but she'll go with the grandson. We're like, still kind of iffy. In the end, they all showed up. It was like 5 family members and then the patient. Wow. And then the husband and the wife, both the patient and the husband, were coughing their lungs out. We're like, you know what? You're going to have to go. We're going to have to move this into a telehealth visit. We could still see you. At that same time, we provided them with the Chromebook and everything. They took it, and then we told them that they needed to go get tested. So they didn't have to wait. We still did a telehealth visit for them. Wow. We still saw them same day. But then come to find out they had influenza. So we're like, oh, thank goodness. So things like that is what we do. And for clinic day, same thing, questionnaire, check temperature, do all that stuff, and sanitize. After each patient comes in, we sanitize the rooms, we spray them down, and then we use a separate room while the other one's sitting for 15, 30 minutes. And then we switch like that.
You said so much in regards to, in the midst of this pandemic, innovation in regards to still being able to evaluate individuals appropriately, keeping patients safe with different methods, from masks to cleaning supplies to putting technology in plastic bags, and all of those just unique things that you and your team were able to do. Just commend you for all that you have done and continue to do in serving our community. I'm going to kind of shift the discussion just a bit. And we want to just, as we kind of want to see if we still have enough time for people to be able to ask questions. But I'm going to begin with Ms. Johnson. And as a result of this discussion, if you would like to leave one important thing that you learned during the pandemic that you want to share with caregivers, and then I'll ask the other panelists as well. But Ms. Johnson, if you can help close us out in our discussion today, if you want to provide us with just one thing that you've learned in this process of navigating care during the pandemic, what would it be?
I would say it would be listening to your friends. You know, you have so many people going through the same thing, and they may know something that you don't know. You know, just because I'm a nurse, people think that I don't know everything, and I'll be the first to say it. But, you know, listening to someone who's gone through what you're going through or going through it, they can tell you little tidbits of things that you don't know. I mean, that's how I found out about the person that would come to the house and give my mother a vaccine, the visiting physicians. Someone told me about the podiatrist that comes to the house.
Wow.
So there's a lot of things that you can learn from other people, and also things like this, you know, little seminars and other things. You can get so much information and so much help. There's so much help out there that people don't know. And they just have to open their ears and listen a little bit, and they can get a lot of information.
Right, thank you so much. Dr. Wright and Teresa, would you like to have, definitely before we end this discussion today, what is one thing that you've learned in this process that you would like to share with those who are a part of our audience today in navigating care through the pandemic? Dr. Wright, you want to go first?
I think for patients and caregivers to stay in touch with their primary care physician. Sometimes people wouldn't keep appointments for a variety of reasons, and you worry, you send out letters, and it was something where, well, we knew that they couldn't come in, and we couldn't necessarily reach out to a lot of my patients in terms of the tech with the virtual visits many times because the equipment wasn't in the home. And if it was in the form of somebody's iPhone or cell phone, and that was dependent upon that individual being there and making it work. And again, and that was relatively, you know, sometimes it would work, a lot of times it wouldn't, especially in the kinds of patients that I see that are not very mobile, that actually have a lot of medical problems that you cannot ascertain over the phone, you know, things like weight, blood pressure, temperature, if they have a valid, you know, thermometer, but just, you know, auscultation, looking at legs, looking at skin and things of that nature. So for virtual visits from a lot of my clientele, it just wasn't there and it didn't work. And so we were faced with saying, you know what, get a test and come in and we'll make sure you get vaccinated. And so for that reason, I did have actually more of my seniors come in, especially when it was relatively low volume during that first year. I could say you come in, have the clinical be empty and mask up, bring one person with you, not a bunch of people, but one person to help navigate and transfer, you know, and we can, you know, and you'll be protected and we can, you know, check your temperature. And when we did start the vaccines, we made sure that as many of our patients did get vaccines just to protect them on the front end, as well as the family members. And so that's what I did. Sure, I didn't see quite a few of my patients that were not coming in and staying safe. I did reach out to them through the old-fashioned phone to say, okay, the mom was there. I mean, the daughter was there with the mom. I'd say, how's she doing? Let me talk to her. I could hear her on the phone, get a sense that she was short of breath, find out if she had followed up with her specialists, which were at least once a year and vital, because a lot of these people had coronary artery disease and heart disease and failure. So that's what I did. And it was kind of hit or miss. I had a few people that I found out from family members that were hospitalized. And I would find out from the family member, not necessarily from the hospital. And I just want to say that I think that was because the hospital was swamped and they weren't reaching out to me like they are now, not in the middle of a pandemic like we had in the midst of 2020. And so many times my first notification of somebody going in and being kept in terms of an elderly person that was hypoxic and having failure was the family saying, do you know Jojo or whomever went to, let's say, Columbia St. Mary's up in Mequon? I said, what? Mequon? He never goes to Mequon. Well, yeah, well, he went to St. Joe's or somewhere, and he was transferred because of no room at the end, which was happening so much in all of our hospitals and our acute care facilities, but especially those in the metropolitan area, because we had a lot of people of color that were going in with shortness of breath. So then I have to get this information from the family member in terms of how many days ago that they were, you know, segued from either St. Joe's or basically just told from the ambulance, no, we can't take him at Aurora. You're going to go up to Mequon for Columbia St. Mary's. And then I had to navigate that. That's not a hospital where many of my patients that are here in the metropolitan area go. So that was a whole new set of work through. I would call, identify myself. I would actually talk to the person who was the admitting, you know, registrar and say, where is this patient located, you know, and say who I was, because I'm young, I don't used to have privileges there. I used to have privileges at Aurora. I refer to Aurora, everybody at Aurora, and most of the people at Columbia St. Mary know the name if you get to somebody there in the internal medicine, but, you know, not so much out in Mequon. So I had to actually work my way to get to the floor, get to the nurse, and basically get to the resident of the day, no, of the week that switches on. And it got to the point where I had to we exchanged phone numbers on my cell phone from the admitting resident of the day of the week, because they kept the same call, you know, cell phone number. And I would call them to try to keep up what was going on. Patients were there alone. Sometimes they were in the unit, sometimes they were in a hallway and waiting in an area because there wasn't necessarily a ward. Family members were nowhere to be found. So once they even went to a hospital that might have been in Milwaukee because of space, a lot of them were transferred immediately within the next day or so to outlying hospitals, such as Columbia St. Mary's. And that's where a lot of my patients went. And the family was just going crazy because not only could they not visit, when they called, they had no purchase in trying and being able to get through to somebody there who would give them any real-time information. So what I found out that was when these folks were transferred, there was also a specialty care facility at the old St. Francis for people that were on ventilators or very, very sick. I had to do a workaround at each facility to make it work for me and say, this is my page, this is my cell phone, call me, give me an up-to-date when they're going to be discharged or if something is occurring. And that was my workaround in several cases when people were at hospitals that were seeing a lot of people and a lot of patients they hadn't seen, and have that interaction. And it was difficult because I had to make phone calls to the family every couple of days when I got a little bit of information in terms of how they were doing. So that was a workaround for me that was different. And it was hard, but you just have to kind of change some things.
And that's, that testimony is so valuable because people need to know how important it is to have a good relationship with your primary care physician, because you were able to connect with other providers and be able to, essentially help walk the family through those situations with someone being in the hospital, where a lot of people found themselves in the hospital and they, their doctor may not have known, or maybe they were in a different role, but you were able to help navigate them. And so that is just so commendable. Teresa, is there one last thing you would like to leave with our audience today?
Well, I think that it's the thought that navigating care is possible. It's finding out that these different ways to navigate care, like how Anna and the UCC, that's phenomenal what they were doing there. So yes. I think, and then how Janice with her mom figured out how do you get care in the home. So I think to me, the main message is everything is possible. It's just figuring out how to get it done. So sometimes it's asking people around you, asking your case manager, asking your primary. I want to, we're having these issues, but I have, can't get there. How are we going to do this? So I think the main thing is that it's all possible and can be done. It's just done in different ways.
Thank you. And Anna, you're going to close us out for the discussion. What's one main thing you would like to leave to our audience about navigating care during the pandemic?
Yes. So my healthcare and advocacy professor once told me her favorite line from Home by Worcestershire. And it was, you only leave home when home won't let you stay. That to me, it's very important because many people don't understand why do people leave their homes? Like, why do they come here? Well, it's because, there's a lot of stuff that doesn't let you stay in your home. So we gotta be mindful of that. So I want to let you know that there are boundaries where there is illnesses for some communities. So it's up to us to be the change to bridge those gaps voiced by the community. And like Teresa mentioned, we just got to find a way to navigate through it. There's always, where there's a will, there's a way.
Well, we want to just thank all of our panelists for adding their voice to this discussion today about navigating care. I'm going to turn it back into the hands of our Associate Director, Dr. Norris. I see there was quite a few questions in the chat. And so
yes, your dialogue and panel discussion today really sparked a lot of questions. I actually don't want to close the session until we at least address one question from the audience. And so to just share a question, one of our first ones at the start of the discussion. This individual saying they have a 95-year-old mother who lives at home with my 55-year-old brother. She is currently going through the level of dementia where girls are coming in the house as she sleeps and takes things. Also calls that she has had it with her family and to sell the home. She cries and always wants her to come over. So any suggestions for her as she's not able to plan any trips? She just needs some advice on what to do with that situation there. If you have any tips or have had that experience of navigating families.
Sure. I hope she is still on. And we say reach out to the Wisconsin Alzheimer Regional Milwaukee office, and let's see how we can help her to navigate this situation and who we can connect her with as well. So yes, so I'm hoping that we can be able to provide her some information to see if there's some individuals who might be able to definitely do a home visit and see what might be happening in that home, and being able to, for her to be able to tell us a little bit more.
Thank you, Stephanie. And one last question, Anna, actually, for the UCC Memory Clinic, is there a fee for the neuropsych evaluation? Do you bill insurance?
So our initial home visit or our initial visits, which is with the social worker and the nurse, is completely free. There's no billing attached to it. The only person that bills is our neurologist, and he, if they don't have insurance, then he's able to see 1 or 2 people uninsured a month. So insurance is not really a big issue. We have seen people come in from Illinois to be seen here by our neurologist due to the language barrier. And we just put them down as no insurance because the insurance from there won't cover over here. So we make sure that we make it available to anybody, even if it's just a consultation via telehealth. We have seen people from New Jersey. We have seen people in Mexico that lived here, but then went to Mexico for a vacation, but still needed the evaluation. So we accommodate as much as we can.
Wonderful. So I just want to thank you all for joining us today. Thank you all to our panelists, to our moderator, to everyone who's attended today for this very insightful discussion. And upon conclusion of today's panel discussion, we ask that you please take time to complete our evaluation. That should either pop up in a new window for you as you close the Zoom, or it will be sent to you via email. As you know, your input is very helpful and informs on our community programs. And so at this time, on behalf of the WAI Regional Milwaukee office, we hope that you enjoyed today's session, and we look forward to seeing you next year for our 9th annual Minority Health Month event. And once again, please reach out to us if you need any assistance for resources, and a recording of this session will be made available on our website. Thank you all and have a wonderful day.